Hey, happy Wednesday morning to everybody. Welcome to this edition of Image Valuation Series. Today we're going to talk about lumbar spines. We do a fair amount of lumbar spines. They're a fun series to do. Let's jump in here and see what we need to see on a lumbar series. We're going to use the same PACEMAN acronym. We're going to run through each of these images and make sure that what is there is what needs to be seen. Um, so for a lumbar spine here, we do an AP and a lateral. And in some cases, we'll do a spot film, which we'll talk about today. But let's jump into the AP. Here we have an AP lumbar spine. It's a pretty good image. Position wise, we're in pretty good shape. So for a lumbar spine, we need to see from T12 all the way down into the sacrum. Okay. Um, we want to include both SI joints. We also want to include both psoas muscles. You can see one right there and one right there. Okay, so position wise, we're in good shape. Area wise, we've definitely got the area that we need to see. Collimation, this is collimated very well. You do want to collimate down on the lumbar spine laterally, but you do not want to cut the SI joints or the psoas muscles off. Okay, this is collimated perfectly. Actually, you can see the collimation lines right here and right here. We're perfectly collimated lengthwise. We see plenty of the spine with the lumbar spine in the center of the film, which is what we want to see. So, exposure wise, this is a pretty good exposure. It's a contrasty exposure, which I like. Um, we're able to see what we need to see. So we've got the spinous processes coming right down the middle of the spine with very minimal rotation. When we start seeing rotation, we're going to see these spinous processes lean to one side or the other if that patient is rotated. There'll be less distance from the edge of the vertebral body to the spinous process on one side than there is the other one. So those spinous processes should go right down the middle of the spine. Okay, we're able to see good intervertebral disc spaces. We can see these pedicles looking at us, kind of like we saw in the T-spine, where it makes an owl face with two eyes right here, and the spinous process is the beak. Those should look like owls, guys. So, which they do. Um, we've got 1, 2, 3, 4, 5 lumbar vertebrae, and then we jump down into the sacrum here. We're able to see good soft tissue. Like I say, we can see the psoas muscles fairly well. We've got good sharp edges of the bone. We got an incidental finding down here of an IUD. Anyway, the exposure on this picture is good. We can see what we need to see. Marker wise, we do have a right marker and it is placed correctly. That can be placed either up here or down here as long as it's not in the spinal column itself. We can tell that that's the patient's right size. Aesthetically speaking, it's a nice lumbar spine picture. You can look at this picture and know that somebody was trying to take a lumbar spine. So yeah, this is what you need to see on an AP lumbar spine, guys. Get that patient nice and straight on the table. The lateral edge of the spine should match the lateral edge of your collimation. They should be parallel to each other. Try to keep that patient as straight as you can on there. It looks better and is more diagnostic. Okay. One thing I will mention, if you're wondering the distinction between thoracic spine body and a lumbar spine body, you can see the 12th rib coming off T12 right here. Okay. And then we've got the L1 right here, and you can just see transverse processes coming off of that one. So you know that is L1. Okay. All right. Let's move on to the lateral image. Position wise, we're in pretty good shape. There may be a tiny bit of rotation And it kind of looks like maybe there's a little bit of motion up here, not so much down lower, but up here near the lungs. Maybe that patient hadn't quite finished their breathing cycle or something. But I wouldn't redo this when we're able to see what we need to see. Uh, Area wise, we've got 5 lumbar spine. We've got number 5, 4, 3, 2, 1, and then we start in with the thoracic spine. Usually, it's not an issue at all on getting what you need on a lumbar spine, just because the lumbar spine is so much shorter than the T spine. If you center correctly, you're going to get it every time. Okay. Um, Collimation wise, we've done a really, really good job. So we need to see the anterior portion or aspects of the vertebral bodies themselves. And we also need to see the posterior elements back here. I like to collimate so I have a little sliver of light behind the patient's back when I'm doing my lateral. Okay. Exposure wise, it's a pretty good picture. Not sure what this is down here. You can see the top of the IUD right there. So I'm not sure what that is. If the patient maybe has something in their pants or something, I don't know. But there is something right there. But it's not affecting anything. But exposure wise, we're able to see good bone edges. We're able to see good intervertebral spaces. We can see the intervertebral foramen really well. These are nice and open foramina, open. Uh, and then we've got the pedicles coming off of that right here. And then right here, we've got the zyga apophyseal joints. So we can see ribs that are superimposed over each other. So rotation wise on a lateral, sometimes it's hard to tell if you're rotated. We should have ribs superimposed over each other, but you can also look at the posterior element or aspect of the vertebral body itself, and those should be clean. You can see a little bit of overlap right here. Maybe a tiny bit of rotation, but you should see just clean lines all the way down. Okay. That's how you check for rotation on a lateral lumbar spine x-ray. We do have a marker. This is the left lateral, which is what we shoot. So it's marked correctly. So aesthetics, it's a pretty good image. It's a nice picture of a lumbar lateral. Uh, like I said before, maybe there's a little bit of motion up here. You see a little bit of blurriness up in here, but not so much down here. Okay. Now, when I spoke about a spot film earlier, you'll note that where the spine comes down into the pelvis right here, and we have our hips, and it kind of offsets it a little bit when we're laying on our side. And that causes that these joint spaces down here between 4 and 5 and 5 and S1 are closed a little bit more. You know that they're open right here, and they're not as open as they are right here. So that's the reason you would do a spot film. So a spot film, you're looking at L4 through S1. Okay, you just want to open those intervertebral disc spaces. Let's look at that one next. So this is a spot film. Okay, and you'll note that the disc space between 4 and 5 right here and 5 and S1 are nice and open. Whereas right here, they're not as closed, or they're a little bit closed, right? So here, we've used a little bit of an angle, usually a caudal angle of about 5 degrees. That's going to open those joint spaces for us, okay? But let's run through this spot film real quick. The position is perfect. The area of interest is shown very well, okay? Collimation is nice and tight, and you are going to collimate tighter on a spot film. So maybe I'll do a quick tutorial video on the spot film and how to do that if you do have to do it. If you've got a patient that's skinny and is pretty straight, their hips don't come out at all. Normally you're going to be okay on your lateral lumbar spines. It's when you get somebody like me that has a little bit bigger hips, and it's going to offset the body a little bit. It's going to close those intervertebral joint spaces. That at that point you may have to shoot a spot film. Okay. Um, One thing about this film is there is no marker. I actually got this one off the internet. Everything else was off of one packs. Uh, but yeah, no marker. But aesthetically speaking, this is a nice spot film. You're seeing everything that we need to see. We've got our intervertebral foramina, our pedicles, our zygapophyseal joints, our spinous processes are all seen in profile. It's a nice picture, but that's what you need to see on a spot film. And like I say, maybe I'll get into a little bit more of how to shoot a spot film. I know that on our L spine uh, tutorial for positioning, I don't think we included the spot film, and I probably should have. So maybe we can do that and get it out there to you guys. I just wanted to show you guys a couple L spines that I pulled off of one packs that you can see a tremendous difference when you use collimation and when you don't use collimation. So this is a AP lumbar spine. It's centered a little bit low. In fact, I don't even know if we're getting what we need to get here. We got 5, 4, 3, 2. So yeah, one's up in here. So um, you know, as far as the spinous processes, they're looking right down the middle of the vertebral bodies. But you'll note that our collimation is way open. Um, you can see a difference between this film and this film. Okay, see how that's nice and tightly collimated, and how our contrast is much better. And we go down here, the one that's wide open, it's kind of washed out. Our contrast isn't as good. The film is just kind of a bland film, and that's due uh, in part to maybe not enough energy in our technique, but also due to poor collimation. We need to make sure that we're collimating our AP and lateral lumbar films. Just keep in mind that we've got to have both SI joints represented and both psoas muscles represented. Okay, so let's look at a lateral that's poorly collimated here. Okay, here's a lateral. I do believe it's the same patient. Got a lot of stool in there. Needs to go potty. Anyway, so you'll note that we're wide open. We've got 5, 4, 3, 2, 1. We've cut off the top of L1 right here. As far as laterality, it's really lateral, which is nice. But again, we're wide open, so our contrast kind of is in the toilet. We don't have good sharp edges to bone. We can't see bony, cortical or anything like that. It's not a great picture, and I apologize if you know that you took this, but it's a good learning process. So you look at this compared to this, you can see a stark difference. So remember to collimate, practice collimation. Sometimes it's tough when you've got a bigger patient on the table and you're shooting an L spine. But practice makes perfect. When you collimate down, you're going to get a better picture. It's going to be less dose to the patient, less scatter. That's the reason these pictures look washed out is because of scatter radiation. There's just such a wide open where those X-ray photons are hitting the body uh, that it's causing scatter, and it's going to affect your film. So uh, anyway, I appreciate you coming by today. Just keep in mind this is what you want to see on an L spine picture. Okay. This is kind of what you don't want to see. Make sure you're practicing your collimation. Make sure you're marking your film, and make sure that you're aware of what you need to see on each film. But I hope this was helpful. If you have any questions on lumbar spines, I love doing lumbar spines. Please reach out to me, and we can run through whatever you want to run through. Next week, we're going to talk about hip and pelvis. Anyway, have a good rest of your week and a great weekend. Thanks for coming by. Appreciate you guys. See ya.